Well, good morning, everyone. I'm Robert Stiles. I'm the program director for the Kansas Disaster Outreach Program, and we are excited to see so many old friends who have been in previous echoes with us, as well as so many new people that are interested in this topic. We're very excited to offer sort of a very brief 1 month series where we're able to really get at the heart of psychological first aid and begin work to help you as you think about how to use this approach in your community. And we've seen a lot of great information in the pre-survey that I know we'll talk a little bit about today, but I know many of you are looking for assistance as you look to respond to future disasters, as well as respond to sort of the current disaster that we've been ongoing on for about a year now. And in response to that, I know you'll find this really helpful. I wanted to introduce our speakers today. Christy, if you could take us to that slide. There we go. We'll start today with Dr. Melissa Maris, who works with the University of Missouri, the Department of Education, and does a lot of work on trauma and other great work with school districts and communities around the states of Missouri and Kansas. Dr. Joel Williams and Dr. Aaron Hembrick are both affiliated with the University of Missouri, Kansas City, and are very strong in areas of trauma and post-disaster response and psychological first aid, which is what we'll be spending the next 4 sessions on, and then move into some work on skills for psychological recovery for those who are interested in that as well afterwards, later in the summer. So I thought I would start today by handing off to Melissa, who will get us started with our introduction today.
Wonderful. Thank you, Robert, and good afternoon, everybody. We're really excited for you all to join us. Just to take care of a little bit more business here at the top, we wanted to disclose that we don't have any financial relationships we need to talk about, and we're not going to talk about any unapproved gadgets. Also wanted to let you all know, in terms of mitigating potential bias, we are going to talk about best practice in the field, so the best of what we know to be true. And Christy, if you want to go to the next slide, that's on there. And also after this session, if you want to go to the next slide, Christy, after this session, we would love if you had some time to really dive into the PFA manual core actions 1 through 3 that we'll be introducing today. There is a link there, and just so you know, we will be sending out the presentation and also the chat log. We hope that you'll be active users of the chat today, ask questions, share ideas and thoughts, and then later on in the session, we will be doing a breakout to have some more, hopefully smaller group discussion. So with that, we wanted to get started just by offering a brief introduction on trauma. And when we think about trauma and kind of the basis and the foundation for what we're going to be talking about here, trauma has become something of a buzzword. We use trauma a lot, we hear trauma a lot. So we just wanted to make sure, kind of from the beginning, to be clear about what we mean about trauma. And we expect that this will continue to be an ongoing discussion throughout our time together. What is included in this work, what is not included. And so wanted to talk a little bit about trauma. So when it comes to trauma, there's lots of different definitions, and it's used in a lot of different ways. Recently, I've been hearing a lot about this idea of big T trauma and little t trauma. So this idea of big T trauma being things that are really obvious, very clear, maybe a car crash or a natural disaster. Little t trauma maybe being something that's an ongoing stressor, something that kind of looks and sounds and acts like big T trauma, but isn't a big T trauma. So we just want to unpack this a little bit here with you today. Can you go to the next slide, please, Christy? Thank you. So when it comes to trauma, just wanted to put a few of these terms out here in terms of what folks are kind of talking about now. Many of you all have probably heard of ACEs, or adverse childhood experiences. Complex PTSD, this idea of acute versus chronic trauma. So lots of different language being used when it comes to trauma. But we really like this idea of kind of an inclusive definition of trauma. And on the next slide, you'll actually see the word trauma comes from a Greek word that means wound. And so, of course, the origin of trauma, a lot of us think about medical trauma, some sort of injury, but of course, we're going to be talking today about the emotional and psychological impact of trauma. And we are going to be focusing particularly on disaster, but not exclusively on disaster. One of the things that we have learned from the research, and it sounds like what you all have absolutely learned in many of your experiences, is that we see similar responses, oftentimes to kind of the big T traumas that I was talking about, as well as the little T traumas. And so we want to kind of think about how these responses and ways to intervene can kind of hang together. What is the same and maybe what is a little bit different? So on the next slide, just wanted to talk through kind of our definition of trauma, and one that we like, this defining the 3 E's of trauma. This comes from SAMHSA, and so this is a pretty widely used definition. I like it because it's easy to remember. So this idea, individual trauma results from an event, that's the first E, series of events or set of circumstances that is experienced, that's the second E, as physically or emotionally harmful or life-threatening, and that has lasting adverse effects, there's the third E, on functional and mental, physical, social, emotional, or spiritual well-being. There are a couple links on this slide there, but the same set definition is used pretty widely. So it's easy to remember, but I think also in this definition, we can really see how trauma becomes really complex, right? So this idea first of an event. Sometimes events are shared in public. So something like a natural disaster is going to be something that maybe perhaps connects a whole community or impacts a whole community, something that can be seen and is known, but not all events that can be traumatic are shared in public and in the community. So when we think sometimes about different types of child abuse or other experiences, some of those may not be shared or known or public. Some events that happen are more, kind of socially okay to talk about, whereas others are not. And so events can really vary in terms of as those sorts of things that can be traumatic. And then experience and effects. And this is really where things kind of get tricky. So this idea that trauma is very individual in terms of how it is experienced and then how something has that effect. So when somebody says, is this event traumatic? It depends, right? It really depends on how the event is experienced and what the effect is. Is this going to have traumatic impacts? It depends, right? In terms of the individual and how it's experienced and the effect. If you want to go to the next slide, Christy. And so one of the ways that I like to think about this is when we think about how our brains work and what happens with trauma. So our brains naturally want to try to make sense of what is happening around us and what is impacting people around us. So what our brains do is we take these events and we try to make things line up so that it really makes sense. And so kind of, I think the clear example of this is we look at one person who maybe has gone through something that we would look at and say is really, really bad. And then we see the impact, and that makes sense because it's really bad. And so it'd have a really big impact. But another person perhaps has gone through something that we wouldn't look at and see as really that big of a deal, but it seems to have a really big impact. And this is when things get really confusing. Our brains want these things to line up. We want it to make sense. And what we're learning more and more through the research and through experience is that trauma doesn't always make sense. Our brains want to make sense of it because it's a way that our brains are keeping us safe and keeping us protected. And so we want to be able to look at something and try to protect ourselves from it happening to us, or trying to figure out how we would respond if it happened to us. But that's just not really how trauma works, because it really is seen through this lens of the individual person. And so again, it's really important that we think about trauma, how we use it, and how we individually and personally understand it, because everything we learn about trauma is really going to be understood through this lens, right? And so I say that because as you move forward doing and pursuing this work with your organization or in your local community, I think it's important to spend time talking about the definition of trauma and what we mean and what we don't mean, and to make sure that we're all on the same page. We have our understanding of what trauma is, and we also have our own lived experiences that we bring to the table. And all of that affects and colors kind of how we're taking in this information, how we encode it, and how we remember it. I also wanted to take that as an entree to invite you in the next 4 weeks and during our time together to take care of yourself. We're going to be talking about some difficult topics. We all bring different strengths and different opportunities to the table in terms of learning about trauma and doing this work. But we also recognize that some of this can be very difficult to talk about. So we will celebrate you taking time to do what you need to do to take care of yourself. And we'll try to build in kind of some reminders around that. But again, as we do work around trauma, we want to make sure that that work itself is trauma informed, right? We want to make sure that we're thinking about how we're learning about trauma and how we can help other people learn about trauma when this is difficult content that can sometimes be hard for our brains to sort of understand and retain. If you want to go to the next slide, Christy. So one of the ways that I often think about trauma and sometimes talk about it is this idea of boats in the storm. And so as Robert alluded to when we started, we have all been through COVID, right? And we've all been impacted by that to different degrees. So in some ways, we're all kind of in a body of water, right? But it's a different storm. It's a different kind of water. And so for some of us, there's really big waves. And for some of us, it's been a little bit more gentle. And so that's kind of what's happening around us and how those things are impacting us. We also bring different things to the table when we think about experiencing these different kinds of events. You know, some of us are on yachts in a kiddie pool, and some of us are wearing floaties in the middle of this ocean, right? And so we have different kinds of boats and it's different kinds of storms. And so even though there are shared components of COVID, or if there's a disaster or a car crash or some other kind of event, there are still those unique aspects that we want to make sure we're bringing to the table and that we're keeping in mind as we're considering this work. So with that, I am going to pass this over to my colleague, Joa, who's going to delve in a little bit more to talk about the impacts of trauma and give us an introduction to PFA. Joa, you're up.
Thanks, Melissa. And welcome, everyone. Good afternoon. And first of all, let me just thank each and every one of you for joining and being part of this virtual space today as we all try to empower ourselves and our communities to be more effective in how we respond to trauma survivors, as we think about how we can best position ourselves to support others and how we can support ourselves. And I want to really reemphasize the point that Melissa made there, that, you know, let me encourage all of us to be mindful in doing this work, to take care of ourselves, find things that are important and nourish yourselves as you think about how you can most effectively support trauma survivors. Because I think that when we nourish ourselves and take care of each other, we're more effective in our response to others in the context of these kinds of circumstances. So I'm excited to have the opportunity over the next few weeks to talk with all of you about some of the specifics of psychological first aid and how this can be a useful framework for us in thinking about how we can approach disaster-affected youth and families and how we can empower ourselves to be better in how we respond to trauma, so that when the time comes, we're prepared to do that. So excited to get to know each of you a little bit more over the next few weeks. And as we talk for the next few minutes as well, if you have questions, let me just say that I'm happy to take questions as I talk. If I cover something that isn't clear to someone, or if someone has a specific question about something, please don't hesitate to chime in with that. Either enter it in chat, or if you want to jump in and ask a question, I'm certainly okay with that too. But please do feel free to ask questions as we go. Now, as Melissa sort of mentioned, she gave us a really nice overview of how we think about trauma and what trauma actually refers to. And generally, when we think about trauma, right, we are often thinking about discrete experiences, sometimes a combination of discrete experiences that occur repeatedly over time, right, that have a lasting sort of effect on us in terms of the emotional impact, the mental health impact, sometimes the physical health impact, impacts on a lot of different areas of our lives. Now, admittedly, as a psychologist, and I'm a clinical psychologist by training, one of the things that I'm often sort of looking for, that I sort of, kind of hone in on in a lot of my work is that psychological impact. What's the psychological toll of trauma? And how can we begin to identify some of those unique sort of aspects of the aftermath of a traumatic event, whether we're talking about disasters or car crashes or other kinds of experiences. So generally speaking, let's just kind of focus in for our purposes, given that this is a psychological first aid training, on some of the very first kinds of reactions that we're likely to see when we're working with folks in the immediate aftermath of a trauma, right? So when you first think about the kinds of things that you're likely to see when working with trauma survivors or working with someone who's very recently experienced a traumatic event, what kind of things kind of come to mind for you? I'm sure that many of you in your own work have probably worked with recently exposed trauma survivors or children, youth families who've recently experienced a trauma. And you don't necessarily have to chime in on this, but if things do come to mind for you, feel free to kind of add that to the chat. But I'm curious, just pause and take a moment and think about what kind of things did I notice in working with that child, with that family? What did the mental health toll look like? And what really stood out to you? And I think it's important for us to be mindful of some of these kinds of reactions, because really this has important implications for what we as responders need to think about doing, I think, when we come in and we try to most effectively support families and kids, right? So I just noticed on chat, someone said that they may seem really disengaged and distant, and that's certainly the case, right? Because when we think about just the overwhelming toll of trauma on multiple levels, especially when we're talking about those acute reactions, that first 24, 48 hours after we've experienced a traumatic event, certainly that can just be really overwhelming for folks, and you can start to feel really disengaged. You may feel really cut off from other people. You may feel really isolated and alone for a whole host of reasons. Shock, right? So someone just said shock. I saw shock as kind of one of those things. Yeah, and so families and children having kind of a lower tolerance, right? You might be just, you might be a little more irritable than usual, might be more keyed up than usual, and so just your ability to tolerate things that otherwise you'd be able to handle just fine might be sort of lowered. That threshold drops a little bit. Acting out with bad behavior, absolutely, especially when we're talking about youth sometimes, and it's also true of adults as well. Sometimes we might see some externalizing kinds of behaviors, right? So that can certainly be relevant. So these are all great, I mean, and great points that folks are making, and I think very sort of accurate observations that folks have noticed from your own work. And anything else? Is there anything else that folks have noticed that you might add to that? That seems really important. If you think about that, please do feel free to add those, because I'd like for us over the next few minutes to think about some of the main things that we might look for. And what are some of the key things that from a mental health perspective, we all really want to be mindful of. I just noticed a couple of folks said avoidance and feeling guarded. And absolutely, right? Those are very common, very natural acute reactions. So when we think about just some ways that trauma can start to sort of manifest on a mental health or sort of psychological level in the immediate aftermath of something, right? There are some key sorts of trauma reactions that you might notice in survivors, whether we're talking about youth or adults, right? That sort of, at least in a biological sense, I think make a lot of sense, right? In terms of why we experience a lot of these things. So let's just go through and talk about some common things that you might look for. What is it that survivors might be experiencing inside that's not always visible, right? So one thing that we often look for that is going to be really common for many people is that in the immediate aftermath of a trauma, at least, again, first like day, couple of days, first week or so, intrusive thoughts are going to be really common. Right? When we think about one thing that sort of is a key feature of psychological trauma and post-traumatic stress in particular, right? Kind of constantly having memories of what you just went through come back into your mind is going to be really common for a lot of people. Okay, so you might find that just when you're sitting around trying to focus on other things and do other things, your mind, maybe just without any sort of cue or anything else having reminded you of what happened, your mind goes back and starts replaying the events sort of, as if you're like watching a movie in your mind, right? And it can seem like it just comes out of nowhere. Much like the trauma itself, a lot of times these memories can seem to kind of come out of nowhere and feel completely out of your control. And those memories often come with a lot of emotional distress. They're really uncomfortable, right? So for many survivors, these sort of intrusive images that cause a lot of distress are going to be really, really common. You might also notice that you have those intrusive memories or thoughts in the form of nightmares about what happened, right? So sometimes it's not so much just during our waking hours that we replay all of these experiences, but nightmares can become really, really common and really prominent in that first few days and first week or so after a traumatic event happens. Somebody else earlier in chat mentioned too that in working with children, youth, and adults who've experienced trauma, you might notice that people sometimes seem really distant, right? And that can be for a lot of different reasons, but sometimes in its more extreme form, that can be because we sometimes experience dissociative symptoms. Now, what do I mean when I say dissociative symptoms? When we talk about dissociation, right, generally there we're kind of talking about a tendency to sort of to kind of withdraw in a sense to a degree that you might kind of lose awareness of even what's happening around you, right? You may sort of lose awareness to some degree, at least, of where you are. You may not necessarily retain awareness of just factual information about identity, autobiographical information, right? You know, or information about the details of what had happened. You may not sort of remember things that people are saying to you, right? So that's sort of what we mean when we talk about dissociation. And sometimes one way that dissociation can happen or can appear is in the form of flashbacks. So you've heard people say that, you know, I've had flashbacks about the trauma, right? Well, flashbacks, at least in a clinical sense, are a little different than these intrusive kinds of thoughts, and that flashbacks generally involve kind of reliving the experience, but feeling like it's happening almost like all over again, right? You sort of don't remember where you are and you feel like you're sort of being re-traumatized all over again. So I mention these here because I think dissociative symptoms are really important to look for. And actually, there's going to be some unique things that we do using things like psychological first aid to help manage these dissociative symptoms in the immediate aftermath of a trauma. So here in the next few weeks, we'll actually come back and talk about how to specifically work with folks who maybe are experiencing some of these more severe dissociative symptoms. But that being said, you're probably not going to see true dissociation happen that often, at least clinically, in a clinical sense. It's much less common than those sort of intrusive memories that people are going to experience, right? But still something important to look out for and to kind of be aware of. But avoidance, and a few folks in chat said avoidance, right? And avoidance is a big thing, especially in the immediate aftermath of a trauma, right? We try to avoid places, people, or things that remind us of what just happened. We might avoid talking about what just happened because it's emotionally just too much, right? And again, avoidance in this sense, at least in the immediate aftermath of a trauma, is often pretty adaptive, right? It kind of makes sense that you don't want to go back to the place where you were just traumatized, or you don't want to experience the overwhelming pain of what you just went through by talking about it with someone else. There's something inherently protective about that. So that avoidance is going to be a big piece of what many people naturally experience in the first few days after a trauma happens. But because those intrusive memories are so painful, right, they're kind of just constantly coming up, you might sort of feel like you've got to look around for danger all the time to keep that trauma from happening again so you can protect yourself. So you might experience a lot of what we call hyperarousal, that feeling really on edge, keyed up, on guard, looking for danger, right? So that's kind of what we mean when we say hyperarousal. That hyperarousal is associated with increase in stress hormones and all kinds of things that can really disrupt sleep. So sleep after trauma usually just gets really disrupted, right? We usually see a lot of interruption in sleep in the sense that you might have trouble falling asleep, you might have trouble staying asleep. So that can sometimes fuel irritability, right? We talked about how your threshold, your ability to sort of tolerate things after trauma sort of goes down very quickly, right? And that can in part be because of just disruptions in sleep and ability to sort of rest and even feel sort of, you know, refreshed and replenished after these kinds of experiences. So all that to say, there's a whole wide range of acute stress reactions and trauma reactions that people might experience. Many of the things that I just talked about here, by the way, are very normal, very common reactions. Again, it makes sense that we look for danger when we've just experienced a life-threatening trauma, or we've watched somebody else go through a life-threatening trauma. So of course we try to take care of ourselves and take care of other people by looking for danger. Our mind replays what just happened because we kind of think to ourselves, you know, if I can remember in some ways the details of what happened, I'll be prepared to handle this the next time I'm in a similar situation. Biologically, there's a reason for a lot of the things that we experience, and there's a reason that we experience a lot of the things that I've just talked about here. So I want to just sort of go over these so you know what to look for, because I think this has important implications for how we all as providers care for and intervene with folks. But know that these are all normal reactions, and especially in the first 24, 48 hours, not necessarily suggestive of any kind of problem, right? We expect this, and this doesn't necessarily mean that folks need mental health treatment per se, right? So we want to just be aware of these kinds of reactions and what people are going to experience. But again, these are fairly normal kinds of reactions that for most people, without any help from any of us, are going to naturally resolve over time, okay? But that being said, these kinds of reactions don't always resolve for people. So there are a subset of youth and children and adults for whom these reactions will not decline. In fact, they're going to continue to stay fairly elevated, and they'll keep happening with the same frequency, same intensity that they did early on, right? So they become kind of chronic reactions, right? And that's where we start thinking about mental health diagnoses like post-traumatic stress disorder and other kinds of things. So why do some folks have these sort of chronic reactions, right? So for some people, why don't these reactions improve over time? And then for other people, why do they improve over time, right? What do folks think about that? Why do these acute trauma reactions generally improve for some folks, but not for others?
Well, I mean, I could tell you the theoretical reason is that substance P is like it's a protein that's a spring basically in the brain, and it gets locked shut, and then it won't release that stress ever again, at least from what I understand.
Yeah, no, yeah, thank you for saying that. And then I'm noticing several folks too here just sort of mentioning, you know, yeah, this combination of nature and nurture, right? I mean, in some ways there's kind of differences in terms of capacity for resilience, but there are also biological reasons that folks may have sort of more chronic reactions, and some folks tend to more naturally kind of recover, right? So influence of past experiences, and you're right, really, if we think about it, there's a real interaction between nature and nurture in that sense, right? The environmental factors that shape our response and our biological tendency to respond in a certain way. So there are key risk factors, right? There's some key risk factors that are in place that we often want to think about that I think are really important and have important implications for us as providers as well, when it comes to thinking about how we respond to psychological trauma, right? And acute trauma in particular. So if we can go to the next slide, let's take a look at some risk factors and some well-known risk factors for who is likely to continue experiencing some of these chronic reactions, or some of the reactions I just talked about in a more chronic form. So if we think about key risk factors that we want to look for, a lot of folks who don't experience natural resolution of these symptoms are going to experience a lot of secondary resource loss because of the trauma, right? So beyond just the mental health impact of trauma, trauma affects a whole lot of different areas of our life, right? We might notice that trauma disrupts our social support networks. Trauma may disrupt even just the most basic, access to the most basic necessities that we all need just to survive from day to day, right? Especially if we're talking about disaster or natural disaster, if my home's destroyed, right? Or if I don't have a safe place to go and I don't have adequate shelter, access to food, medications, things that I might otherwise need. We're talking about significant resource loss, and it's going to be really, really hard to think about ways to cope with everything I'm experiencing psychologically if I'm preoccupied with just making sure that me and my family have what we need to get by day to day. So when trauma adversely affects other resources in our lives, that's a big risk factor for making those sort of reactions more chronic, or for those reactions sort of becoming more chronic over time, or not successfully resolving. Similarly, isolation and withdrawal, right? We know that social support, and good social support in particular, is really protective. But when we don't have that in place, that's a big risk factor for more chronic post-traumatic stress kinds of reactions. But extreme emotional distress at the time of the trauma, right? So we talked about dissociation and how that can be kind of an example of an intense kind of peri-traumatic reaction, is the term that we would use in the psychological literature, right? But thinking about just the intensity of the emotional reaction in that first 24 or 48 hours after a trauma happens, that's been a well-known risk factor for later kinds of trauma-related mental health problems like post-traumatic stress disorder in particular. But sometimes we might even find that in that first 24, 48 hours after a trauma, we really start wrestling a bit with thinking about why this just happened. If only I had done something differently, maybe I could have prevented this from happening, right? Or I start to feel really guilty that I didn't do something to change what happened to me or somebody else that I loved, right? If I had only done something differently, maybe the outcome would have changed, right? So those kinds of negative cognitions, those negative thoughts that we might start to wrestle with a bit, can also have pretty detrimental long-term impact. And so that's another risk factor for more chronic kinds of reactions. And similar to isolation and withdrawal, poor social support. Just because we have people around us doesn't necessarily mean that that support is always quality support, right? Sometimes negative support can be just as much a risk factor as being socially isolated and withdrawn. So I point these things out because these are all really important risk factors to be mindful of, and risk factors that we want to think about when we're working with folks in the first 24 to 48 hours, right? Because really what we have the opportunity to do, knowing that people are experiencing certain kinds of reactions and that there are well-known risk factors in place that may predict who's likely to continue experiencing those reactions long-term, we then have an opportunity, I think, with early intervention to come in, help provide some emotional support, help alleviate emotional distress, and start trying to figure out how to address certain risk factors that might be most relevant for that child, that teenager, that family, right? Because if we can start addressing those risk factors early on, right, then we give people the skills that they need, the resources that they need to naturally begin the process of recovery without ever having to come in for a formal mental health treatment, hopefully down the road, right? Or at least we create conditions where that may be less likely what they need down the road. Now, for some folks, they will still need some intensive mental health services, right? And in that sense, this can be a big bridge to getting folks connected. But that being said, with early intervention, like psychological first aid, which we're going to be talking about next and through the next few weeks, we really just want to come in and help try to provide some emotional support and start addressing these risk factors, right? Again, putting folks on the trajectory towards resilience and recovery. So let's think about what psychological first aid is. Let's introduce that, and let's just talk a little bit about that and think about how that fits in the continuum of care here. So if we can go to the next slide. So psychological first aid, right? What is it that we're going to be talking about for the next few weeks, and how does it address some of the different concerns and issues that I've just talked about? Well, with psychological first aid, we're talking about an evidence-informed early intervention. And when I say early intervention, I mean kind of immediate first 24 to 48 hours when folks are experiencing a lot of those kind of psychological reactions that I talked about. When we may really benefit from additional supports to help mitigate some of the risk factors that we just sort of mentioned. So psychological first aid is, again, an evidence-informed early intervention that really aims to try to provide some immediate practical assistance to folks who maybe lost a lot of resources because of the trauma, right? Or didn't have resources in place even prior to the trauma to help them adequately manage and deal with and cope with the stress that came from the traumatic experience. So we want to try to think about, how do we provide people with practical support? How do we address that risk factor? how do we link people that are socially isolated, right, or don't have good positive social supports to meaningful social supports so that they can begin the process of natural recovery, right? That's something we want to do with things like psychological first aid. How do we give emotional support to help lessen the intensity of that immediate emotional distress, right? To try to, again, help give people the resources that they need to begin to naturally recover on their own. So I kind of like thinking about psychological first aid as a way of enhancing resilience, right? This is really a natural way of just drawing on people's strengths, addressing what's not there and trying to give some supports so that people can, again, be as resilient as I think humans and people naturally are, right? So we're really just supporting natural resilience with a lot of this. This is intentionally brief. Again, we're talking like 1 to 3 contacts. Psychological first aid is not something that's, done over the course of, months or years necessarily, like a lot of people think when they think, psychological services or therapy, right? Here again, we're not talking about therapy. We're talking about just, some immediate practical assistance and support that's very brief. And you can do this, in as few as 1 contact. In fact, a lot of the times when we've done psychological first aid with folks, it generally has been like maybe 1 session, right? So, I mean, we're talking about really intentionally brief kinds of things. And I think what will become obvious to you over the next few weeks is that with that 1 session, we can have a real impact on folks' lives, right? There's a lot we can do with 1 contact. And I think it's more, what do we do with that contact that counts, right? And what's most important to that person? And how can I be most useful to this family right now in their time of need? And if we can really do a good job of trying to understand what it is that folks most need and want from us in that moment, we can do some pretty remarkable things. So we're going to talk about what psychological first aid looks like, how you decide what to do with that family, and that's going to be, something that we'll consider a lot over the next few weeks. This link was just shared with you earlier on, but again, you can access this manual for free. So the Psychological First Aid Manual is publicly available through the National Center for PTSD's website. The National Child Traumatic Stress Network also has a free online training for psychological first aid that I would strongly encourage folks to check out. I think it's really well done, and it can kind of give you a sense of how a lot of the things we're going to be talking about over the next few weeks look in practice, and it has some really nice scenarios to sort of supplement and augment a lot of what we'll be talking about together. So that when folks, come back for the next time, when we see you again next week, maybe you'll have some additional kinds of information and examples to draw from. But again, PFA, really, we just want to identify needs, provide emotional support, and this is done kind of with the intention of being fairly brief. Now, again, one of the things that I think is important to understand here that I just want to kind of remind folks again, this is brief by design because we're intervening early, right? First 24, 48 hours. So just to put this in the broader context of how something like psychological first aid fits within the continuum of behavioral health care for trauma survivors, let's go to the next slide, and I'll just kind of give you a sense of how this looks and how this works in practice, right? With psychological first aid, really the goal is sort of what we call primary prevention, okay? So we're trying to prevent the development of more chronic long-term mental health problems that can sometimes result from psychological trauma or result from trauma exposure, right? So it's kind of considered a preventive intervention in the sense that, again, we're intervening early by addressing risk factors with the hopes of trying to create conditions where folks will be more likely to naturally recover. So this is an acute intervention that's available to all trauma-exposed youth and families. We don't necessarily screen folks for their appropriateness for an intervention like this. It's considered to be pretty universal, right? It's kind of considered appropriate for anybody who's been recently trauma exposed. But that makes it a little bit different from other things that we'll be talking about in the next few weeks, like secondary preventions, for example. So once the PFA echo over the next few weeks is finished, later on this summer, we'll actually do a series on a secondary prevention, skills for psychological recovery, which is a little bit different and a little more intensive, right? This is the kind of stepped up intervention, if you want to think of it that way, that's really relevant for folks who continue to kind of notice that they're having some elevated symptoms, or elevated kind of, trauma reactions that are still causing some problems and that they're still really struggling with. And if you notice that that's the case, right, sometimes you can benefit from more intensive early intervention, but again, still we're not talking about therapy or treatment for mental health problems per se at that point. But again, secondary prevention, like skills for psychological recovery, is further still different from actual mental health treatments, right? So things like trauma-focused CBT, PCIT or parent-child interaction therapy for folks who are familiar with that, right? There we're talking about actual mental health treatments, okay? And that's really only going to be appropriate for a smaller subset of trauma-exposed kids, families, and adults, right? So again, most people are never gonna need that level of care, but almost everyone, we're going to argue, I think can benefit from just some of the basic supports that we'll do with something like psychological first aid. Okay. So any questions so far? All right, I'm going to keep going here just because I want to make sure that I'm also mindful of time. But in thinking about continuing just to kind of differentiate some of this, let's go on to the next slide real quick. And I want to differentiate psychological first aid from a couple of other models that I know some of you might be familiar with and may wonder, how is this different from some of these other sort of approaches that you might have heard of? A lot of folks have probably heard about mental health first aid, right? I know there's been a big push for mental health first aid. And a lot of folks are probably familiar with that idea. And I think it's great to certainly get involved with mental health first aid if you have the opportunity to. But again, that's a little bit different. So just kind of make sure that you're familiar with the differences between these two approaches. Because with mental health first aid, we're talking about a protocol that teaches you to kind of recognize and intervene when a person is starting to experience a mental health problem or in a mental health crisis more broadly, right? So if I notice that somebody's having intense anxiety or panic kinds of symptoms, for example, or maybe I'm concerned about somebody that I think has a worsening substance use problem, something like mental health first aid might be appropriate for that, right? But that's very different than what we're going to be talking about, psychological first aid, which is really a specific set of skills for helping people in the aftermath of trauma and disaster, right? So mental health first aid is much more broad in that sense and isn't necessarily specific to a lot of the concerns that trauma and disaster survivors will have in the immediate aftermath of a trauma. So just, so both useful, I think, but think about when each one might be most indicated, right? So that's just one important difference there. I'll also want to go on, we can go to the next slide. I want to make sure that folks are also aware of just some of the differences between psychological first aid and another common early intervention that many people might be familiar with, psychological debriefing. So that's also, it's also in the literature sometimes called critical incident stress debriefing, right? And a lot of folks may have heard about CISD or variants of psychological debriefing kinds of interventions. But this was an intervention that, like psychological first aid, was kind of developed to be delivered with trauma survivors in the first 24 to 72 hours after a trauma happens. This was actually originally designed for emergency services personnel, and we can talk about this a little bit later, and I won't get too much into it now. PFA was actually developed more in response to disaster related contexts, unlike debriefing, but both were developed to be administered to trauma survivors in the immediate aftermath of a trauma. But unlike psychological first aid, which is often done on a one-on-one basis or with families, right? Maybe with a family-specific kind of context, debriefing is often done in a group. So psychological debriefing was designed to be done with an entire group of people, all of whom had experienced the same kind of thing, okay? So one key difference there, I think, just to be mindful of. PFA is often done one-on-one with the client, an adult, or a family, or a child or their family. This is done usually in a big group format. If we go on to the next slide, there's some other important differences that I also want to draw your attention to, and that psychological debriefing, generally, if you think about debriefing kinds of interventions, these kind of interventions operate on the assumption that we want to get folks together and have everybody kind of discuss details about the trauma and their emotional reactions to the trauma. So everybody in the group is typically encouraged to kind of talk about your reactions to what you saw, how you've been dealing with it, and kind of, openly discuss that with other trauma-affected individuals. The person who's running the group, or the debriefer, generally then kind of normalizes those symptoms and then gives folks education regarding healthy coping, okay? That's what most debriefing kinds of interventions typically look like. But one of the reasons that I'm also drawing that distinction here is that if we go on to the next slide, I also want to point out just some important information. Several studies over the last couple of decades have actually started to conclude that, based on the results of randomized clinical trials at least, that psychological debriefings generally no more effective than no intervention when it comes to actually reducing trauma-related symptoms, say 3-6 months down the road, or in some cases may actually worsen symptoms for some people. So that had left a lot of people in the field kind of scratching their heads and saying, well, why is that? Because so many people say that they benefit. So what's going on there, right? So I wanted to sort of point that out to folks because there's been kind of an important push in the field, I think, to move away from debriefing in favor of other kinds of interventions. But folks also said we don't want to throw the baby out with the bathwater. There's some important things about debriefing that we might want to keep, right? So in thinking about that over the next few weeks, we'll draw some sort of comparisons to debriefing, but talk about how this is different. But again, I think one of the key things that for our purposes is going to be critical to remember is that one thing besides just group and one-on-one format that's different about psychological first aid from debriefing is that in psychological first aid, we focus on what is most important to the child or the family that we're working with. And that may or may not mean that we actually process emotions and thoughts related to the traumatic event itself. If that's the most pressing thing for the family, that's what we do. But we also don't encourage people to talk about those details if they don't want to and if there are more immediate pressing concerns. So I think there's been kind of that move to sort of, move more towards what's the most relevant concern for the person I'm working with. And that's going to be a key difference, I think, between debriefing and PFA. So for folks who are familiar with debriefing, I'll be curious over the next few weeks to see, sort of what similarities and differences maybe you see in something like psychological first aid compared to debriefing, because I think there are some key things that are similar and a few things that maybe are a little bit different. So if we go on then, let's just go through because I want to wrap up. I'm already a little bit over time on my section here and I want us to get a break in before we do anything else. But if we go on to the next slide, so Christy, if you can move to the next slide for us, just some basic information. Who can deliver PFA? Honestly, almost anyone. That's the beauty of the intervention. That's one of the most beautiful things about psychological first aid. It can be delivered by victim advocates, chaplains, other professionals, almost anyone who is involved in early response for trauma and disaster affected youth and families. So you don't have to have a specialty degree in mental health to do this kind of intervention, right? So it's by design intended to be applicable for a wide range of professionals. So if we go on to the next slide, you might sort of wonder, where can PFA be delivered? Again, one of the beautiful things about this protocol, right, and this intervention, can be delivered in a whole variety of settings: hospitals, emergency departments, over the phone, local police departments, schools, right? So I mean, there's a lot of places where we can do this kind of approach. Almost anywhere that we can find survivors and talk with them in a safe, comfortable, and private place, we can do this kind of intervention. And so one more slide. And just to give you a broad sense of how psychological first aid has started to garner more widespread attention, some examples of agencies that have adopted psychological first aid for trauma and disaster survivors include Centers for Disease Control, the American Red Cross, the World Health Organization. So folks are starting to sort of recognize the value of some of the skills and approaches embedded in this protocol that we're going to be talking about soon. And I hope will become an important part of your own toolkit when you think about how you can respond most effectively to trauma and disaster survivors in your own settings and your own communities. So my apologies for running a little bit late, but we've got some fun stuff to talk about here soon. So I'm going to hand it over to Erin, and I know we've got
yeah. So my role here is basically just to say thank you to Dr. Maris and Dr. Williams for providing this great overview. We're going to take a 5-minute break, so please come back at 1:55. We will do a little more didactic. I will introduce the first core action of psychological first aid, which is contact and engagement. And then we will spend a lot of time in some breakout groups, really digging into this first core action. So we will see everybody back at 1:55. Thank you. Right, I see that people are starting to pop back on. Some videos coming back on. So just in the interest of moving us all along, I'm going to go ahead and get started. Something that we all love about psychological first aid is that there are a lot of great things to talk about. The psychological first aid field operations guide really is divided into 8 what we call core actions. And these 8 core actions, some of you were probably at our early interventions webinar, so you already have this sense, but not everybody. So a little bit of this today will be repeat for those of you who joined us at the webinar. Something that's really great about these core actions is that they don't have to be used in order. And to deliver psychological first aid, you don't have to deliver all 8 of them. You could deliver one core action to one person at one point in time and walk away and know, that you did your part and that you played a role in providing psychological first aid. We are going to cover them in order. So today we're going to talk about contact and engagement, which is really, if you're only going to do one intervention, this might be the one that you do, right? Because in order to intervene, we have to have an initial contact with individuals that really sets the stage for our future work. So Christy, next slide, please. So in the spirit of setting the stage, there are some things that people who are interested in delivering psychological first aid should really be thoughtful about. In order to provide psychological first aid, you don't have to have a mental health background. And in fact, people who don't have a lot of mental health training, in some ways have a little bit of an edge in terms of providing psychological first aid, because it's very different than the mental health interventions that a lot of mental health providers are trained to provide. These interventions that you engage in once, for example, a person has some sort of mental health diagnosis. We have a pretty good mix, it seems. Thank you so much to those of you who filled out the pre-survey. It really helps us in terms of understanding our audience and your needs. And it seems like about 3/4 of you do have a mental health background, but then that leaves a full 1/4 or 1/4 of you who don't. And I'm so excited to see that great mix here today. And if you are interested in providing PFA, here are just some great considerations. Having the ability to work in chaotic and unpredictable environments is really key. When you are in the aftermath of disaster, unpredictability and the need for flexibility is the norm, not the exception. And so, are you the type of person that copes well under those circumstances? Now, certainly many of you in your professional roles, whether you like to work in chaotic environments or not, sometimes find yourselves in this situation where you are needed, regardless of whether or not you consider this to be your strength. So I also want to note that this ability and capacity can be built, especially with a great mindset. And I appreciate that the self-care resource was just shared, because going in with the mindset of I have to be able to function in a very unpredictable environment can help you succeed. You also want to have or develop the capacity for rapid assessment of survivors. You don't have the opportunity often in disaster situations and scenarios to have lots of information at your fingertips about a person's past, about their history of mental health functioning, about their medical history, about their cultural context. You want to have the ability or hone the ability to provide services tailored to context and culture. And I really can't emphasize this enough. And this is another reason that we really encourage you to be reading the Psychological First Aid Manual alongside your participation in this series, because they have the opportunity to go a lot more in depth here. but spending time to reflect on who you are and the biases and assumptions that you bring to an interaction with another person is going to be key, because we, can you actually go back to, yeah, thanks. Because when we are interacting with someone, again, we don't get to know a lot about their past. And so we have to stay very assumption free. We don't want to assume that just because somebody experienced a flood, that they are completely overwhelmed. Maybe in the course of their life, this is actually a very small thing. And in fact, they're feeling very gathered and in control and actually ready to help alongside you as part of the disaster response. You also want to have or hone the ability to tolerate intense distress reactions. So we're not saying become a robot, and we're not saying don't become genuine, because part of being a great PFA provider is actually the capacity for connection to others in moments of potentially extreme external chaos. But what we mean here is that your personal stress reactions should not be getting in the way of your ability to connect with others. Are you in an emotional or a psychological state in which you can put your own reactions aside, at least for the time being? You also need to be willing to accept tasks for those, the 3/4 of you who do have mental health backgrounds, the willingness to accept tasks that aren't initially viewed as mental health activities. We are in the business here of preventing later mental health problems, but we are not addressing mental health diagnoses. We are getting at practical needs. We are trying to set the stage for healing and recovery, and that's very different. So again, as you think about when and in what contexts you might be a really great psychological first aid provider, I really invite you to look through these pause, reset, and nourish resources to be thoughtful about how you can best take care of yourself so that when disaster strikes, you'll know if you would be a great psychological first aid responder. All right, go ahead to the next slide, please. So just a discussion question to get us thinking through this issue. After receiving psychological first aid training, Fred was asked to respond to a tornado that has severely impacted a nearby county. If you all could offer into the chat, what are some considerations that Fred should make before agreeing to the deployment? What things should Fred be considering when thinking, am I the right person for this job? Yes. What are his triggers? Have I previously experienced a tornado, and how might that interact with my delivery of care? Capacity to be present. Yes. See himself affected by this tornado. Goodness, absolutely. This will be a theme throughout our entire psychological first aid training. Disasters are often shared events. And what that means is that many PFA providers are also people who are currently being affected or have previously in some way been affected by the same disaster. Personal experiences. Yes, absolutely. What's home life like right now? Is this an okay time for me to leave, or will I be distracted by current things going on in my life? Yes, exactly, Jessica. What are the other stressors that are pulling at him that might make it hard to be present? Go on to the next slide, please. So now that we've talked about some kind of provider level considerations to constantly be mindful of before we engage in the application of psychological first aid, because these considerations will come and go, right? I could have been a great provider yesterday, but maybe today I'm not because of something new that has occurred, or because of the depth of response that I provided yesterday. Now, today, I need to back away and let other people take the lead. Let's talk a little bit about contact and engagement and kind of the definition of this core action. So moving on to the next slide. So contact and engagement, some of the things that or some of the words that really define this core action, or principles, overarching principles for this core action, are respect, sensitivity, empathy, warmth, and an encouragement of mutual trust. Right. So again, this is very tied to pre-intervention considerations. It can be hard to be empathic if you yourself need a lot of empathy today or in this moment. I also want to call attention to the fact that Joe Williams and I were talking about contact and engagement a little bit this afternoon before the training. Contact and engagement, this core action can seem deceptively simple, because all of you are probably looking at this list and saying, yep, that's how to be a good person, right? Like, this is how we human with one another. Absolutely. Absolutely. But part of the trick, part of the job, the role here is keeping all of this in mind. My job is not to heal someone's mental illness. My job is not to take away what has just happened to them. What has happened has happened. My job is to be with them in this moment, to respect what has happened to them, and to respond in the most human manner possible. Let's move along to the next slide. So in terms of contact and engagement, some do's and don'ts before you, what do I mean by make contact, right? Before you go and meet and speak with someone who's just experienced a trauma or a disaster. We really want to make this about the other person. Those of us who are kind of feel compelled to get involved in helping situations and professions, we want to be helpful. It's the natural inclination to want to do. But a lot of contact and engagement is about doing less and observing more. So we want to observe, what's the scene like? What's the culture here? What seem to be the prevailing norms? How do they differ from my own? We want to ask simple, respectful questions instead of saying things like, you must be traumatized. I can't believe what you just went through. Tell me what happened. Can be a different way to approach the situation. We want to speak calmly and slowly without jargon, and always acknowledge survivor strength. We never want to assume that just because something has happened, the person does not continue to have self-efficacy and agency. And so on the converse, we really want to avoid making assumptions about experiences. I can't believe this has happened to you. This must be one of the worst experiences of your life. Maybe it is, maybe it isn't. And maybe now that you've said it, the person's like, oh gosh, this is the worst experience of my life, right? We don't want to allow our words to make things worse than they need to be. We don't want to label any reaction a person is having as a symptom. If they're crying, they're crying. Right? That's kind of a behavior. That's not a symptom of depression. They've just experienced something potentially life-changing. But we also, on the converse, don't want to talk down or patronize or act like we know more about their experience than they do. So move along to the next slide. So what do? We want to establish a connection in a non-intrusive and compassionate manner. Simply introduce yourself and describe your role. Ask for permission to talk. I'm a clinical psychologist by training, but I'm never Dr. Hambrick in a situation like this. I'm always Erin. Hi, I'm Erin, and I'm here with maybe with the University of Missouri system. And is there anything I can offer you right now, right? We want to keep things very simple and ask about immediate needs. Next slide, please. So here are just some sample introductions that tend to be great ways to kind of break the ice and make a first connect with someone who's just experienced a disaster. May I ask your name? Before we talk, is there something you need right now, like some water? Hi, this is my name. This is my role. And is it okay that we talk? One of my sisters lived in New York City during Superstorm Sandy. And one thing she always talks about is that the most helpful thing for her was that there was a coffee shop down the street from her apartment. And every time she walked by, there were signs in the windows that said free electricity. And anytime she needed to, she could go and plug in her phone and have enough charge on her phone to call people to tell them I'm okay, right? Because a lot of apartments didn't have electricity. And that really simple and practical act was something that helped her find meaning and feel connection, right? It wasn't a lot, but it met a very practical need at the right time. So next slide, please. Couple of considerations before we move to our breakout rooms, a couple of developmental considerations. If you get into the PFA manual, you will find considerations for young children, adolescent children, older adults, all throughout the lifespan. So I encourage you to do that. But when working with children, there are some particular contact and engagement things to think about. You know, we want to meet them at their level. We don't want to use a lot of intense eye contact because we are trying to get them to engage with us. We're not looking to intimidate in any way. We want to match their developmental level. We don't want to say, oh, you've just experienced a disaster. And we want to check for understanding. You know, if you've expressed something for a child, you might nicely find a way to kind of say, hey, do you remember where I told you that the bathroom in the shelter is, right? And see if they can point it out, that sort of thing. Talking to adolescents, adult to adult, not expecting that they're very young and helpless. And avoiding questioning. I think this is so important. It's easy to want to kind of, how are you feeling? What do you need? Tell me about this. Tell me about that. But really, being questioned in a time of potential distress, it's hard to answer questions. And that can also kind of amp up the stress response instead of bringing it down. And so I think, you know, we're asking you during contact and engagement to actually do very little, and that can be hard. But remember that you are an excellent model for any parents or caregivers or other providers who might be around. And if they know you have this training, they're going to follow your lead, and they're also going to respond in respectful and hopefully stress-reducing ways. All right, next slide, please. So we are now going to move into 4 different breakout rooms. And when you get there, I'll allow your breakout room leaders to kind of orient you to the task. But you will be engaging in some scenarios relevant to contact and engagement. And we really want you to do this because in a disaster setting, if you haven't practiced something, your stress response system is going to be activated too, probably, and you won't be very good at doing something that you've never done before. So we really want you to begin practicing and routinizing some of these ways of engaging with survivors so that when you have the opportunity to provide PFA, you'll be ready and prepared. So have a little bit of grace with us as we split off into these rooms, but we're hoping that it will go off without a hitch. Great, great. So I just want to, I don't know if the right word in this context is debrief, but just bring us back together related to the examples, although I don't know, are we all back?
Yes.
Looks like it. Okay. So really appreciated the discussion. A couple of key things came up. One, in at least our group, was related to developmental considerations. You know, how might you make contact and engage differently if you're working with someone who's older versus younger? And something we really talked about is kind of, you know, maybe the contact and engagement, the initial one, isn't even verbal with a younger child. Maybe the initial way that you show that you're a potential resource for the child is by, you know, kind of potentially coming into their eyesight and, you know, playing with a fidget spinner or a game, or showing that you're regulated and that you are interested in meeting a child at their level. So really thinking about nonverbal communication is so important. Another thing that came up, especially for scenario 2, was related to some potential considerations if there might be some language differences between yourself and a person that you are trying to engage with. Maybe there are gender or race ethnicity differences, and at least in the case of scenario 2, we were thinking about, what if there is potentially a race ethnicity difference? And one thing that we discussed, and this is going to look different in every scenario, so it's incredibly important to begin thinking about early, is that I think sometimes we focus on what do I do because I potentially have some differences from this person. But remember, when we first started talking about contact and engagement, we talked about really trying to think about the worldview of the survivor and dropping any assumptions that we might have. And so remembering that they might react differently toward you because you might be novel in some way. And it just might take a little longer to build trust. It might take a little longer to be seen or considered to be someone that this individual might want help from. It also might not, right? We don't know until we begin. But it can be so important to observe first. And I think to be very thoughtful and mindful, and this goes back to, please don't provide PFA unless you yourself can be present, to be thoughtful and to be mindful about what assumptions are running through my mind when I see this 6-year-old child. Am I immediately perhaps negatively judging the parent? Where are the parents right now? And how might that translate in my body language? How do I need to watch that and check that? Is the first thing that goes through my mind, where's the mom? Why isn't the mom here? Well, maybe in this culture, the correct person to first speak to in a family is the father, right? Are we thinking about this? Are we noticing the assumptions we have when we see a situation? And then are we running them through the context of who we are, what identities we hold, and then being thoughtful about how we proceed? So, there's never going to be a textbook answer for how to proceed, but I do think that thoughtfulness and really engaging what assumptions am I having and where do they come from is going to be a very important first step. Do other breakout room leaders want to expand on that at all? Or anyone, actually? I also just wanted to say, feel free to jump in if you want, but I also want to say here that hopefully the idea of personal contact came up in all of the rooms, and how not only is it not advised to lead with personal contact, but we even want to be thoughtful about whether or not we ask if someone would like touch, because sometimes, especially younger children, can be a little overly compliant when they feel stressed, and they might say yes because they think that's the right answer. So observing, always observing. So can we go ahead to the next slide? So I want to say a little word here. In the future trainings, we are going to make space in about the last 25 to 30 minutes for you all, our participants, to present scenarios that maybe you've experienced or that you're likely to experience, and we will talk them through and troubleshoot them as a group. We're not going to do that today, but that is going to be a really important part of our next 3 sessions. And so if you are interested in being considered for one of those scenarios, it's not too late, and we would love to hear from you. But kind of another word, just in reviewing the scenarios that we've already received, it was a really great reminder that you all are, our participants are finding yourselves in lots of potentially psychologically challenging situations day to day, and bring a lot of great insights to the training because of that. And we just also really look forward to learning from you all, and how you have built resilience as professionals and as professional communities given the experiences that you've had. I also want to just kind of touch on who we are as a group. So one of the overarching goals of psychological first aid is building community self-efficacy. And it's not always the best idea when a disaster strikes for an expert out of town to come in and be the one providing disaster response. Sometimes that is indicated and needed for a variety of reasons. But a lot of the research suggests that communities that can help each other and help themselves are going to get much further along on the path to recovery. I worked a lot with the community in Joplin, Missouri, about a year after they experienced the devastating tornado. And in many disaster research and response contexts, Joplin was really considered a model community in terms of how they got through that and rebuilt. And something that interested me, I was like, why is that, right? I'm a researcher. Why is that? Why are people calling Joplin a model community? But they had a lot of mantras, community-wide mantras that focused on their own resilience. We will build back stronger, those sorts of statements. And they were also kind of a mid-sized city. And in some ways that provided them the ability to really connect with each other after the big tornado happened, right? We know who the folks at the Red Cross are, we know who the people at the state level are. We know who to contact for emergency services. We know who the hospital administrators are, and we can convene all of these people and pool our resources and be connected in our response. So again, we really want this set of trainings to be a way that we can all connect with one another and learn about the roles that each other play, so that when well, I guess I'll say when, because unfortunately disasters are happening more and more frequently. When disasters or bad things occur, we'll know who to contact and how. So there's a lot of shared expertise in the room, folks from school systems, folks from private practices, folks from big hospitals, and each of you bring a unique lens, but also in the event, especially of a large scale shared disaster, each of you will have an important role to play in terms of recovery. So if you could go to the next slide, Christy. I also just wanted to bring up two of the questions from the pre-survey that you all took, just to kind of show that even though we all have different roles, in many ways we're all in the same boat, like Melissa was talking about at the beginning. Lots of you were saying that you need help assessing the strengths and weaknesses of your current response protocol of your organization. And that really seemed to be a shared theme amongst the majority of you. And so you're not the only person sitting here thinking, actually, if something bad happened at my school, I don't know the chain of command. I don't know who's in charge. Maybe we don't even have a plan. And I see your role in participating in this training as being an important person at your place of work in your community to start asking these questions of others who live in your community. What happens here if there's a large scale disaster? What happens here if there's a child at our school that has experienced something traumatic before they come to school and they disclose it to somebody? What happens? Who helps? Whose role is what? And those will be themes that we will talk about throughout this training as well. If you'll move to the next slide, Christy. And again, just pointing out here, a lot of you said that your level of expertise related to working with children and families in the early aftermath of trauma exposure is competent. A lot of you also said hey, I'm still kind of novice and new of this. So we have a lot of competence in the room. And then we also have a lot of people who are newer to this and who are looking to connect. So I think we have a really great mix of expertise levels, even some people who are like, I've been doing this for a really long time. And I don't know, maybe they're here to see if there's anything else they can learn, or if they can be better connected to the community. Next slide. So what we want to do now as a closeout is just kind of recognize that we have been talking about trauma and disaster for almost 2 hours now. And this might have brought things up for you that you feel motivated to do. It might have brought things up that you're hoping to try. It might have brought some new insights. I don't really know where each of you are on your learning journey here, but we would invite you to click the link that's in the chat bar. So Robert Stiles just put a link in the chat bar that we would invite you to click. And when you go and click that link, please place a word that you leave this training today reflecting on. And then as the words come in, we'll kind of get to see them here up on the screen. Enlightened is really coming through. Really gives me some joy to see that. Calm and listen. Absolutely. Rapport, community. Yes, patience with ourselves. We want to do something to help, but in this context, it can be so paradoxical. Permission, thank you. Yes, it's always placing the needs of the person that we want to support first. Grace, absolutely. We have to be graceful with ourselves. We're not going to do this right every time. We're going to make contact and engage with somebody in a way that we're like, whoa, that was too much. I'm going to back it up next time. Great. Thanks for continuing to weigh in. So just as a reminder, as we check out today, I think you will get the most that you can out of the future sessions if you go and check out the PFA manual. And next session, we're going to focus on the next 2 core actions. Core action number 2 being safety and comfort, core action number 3 being stabilization. So please, if you can, take a look at those. And we will come back here next week for more of the same. Robert, is there anything you want to add here as we end?
So we'll send out a link to the video, a copy of the PowerPoint, a copy of the word cloud, the resources today, and the chat. And thanks for your patience today. As we did our first breakout room, we have it down now, and it'll go really well next time. We're positive. So thank you for your patience through everything, as well as your participation. Have a great week, and we'll see you a week from today.